Welcome to CANVax's Webinar Series. This series launched last year in fall 2019, and due to popular demand and high engagement, we will continue to host webinars throughout 2020. Our purpose of hosting these webinars is to support and inform the work of public health professionals to improve vaccine acceptance and uptake. To learn more about our upcoming webinars, please visit our website at canvax.ca/CANVax Webinar Series, as indicated in the link you see on the screen. Before we begin, we would like to acknowledge that CPHA's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. CANVax would also like to express our deepest gratitude to all frontline essential workers dealing with the COVID-19 pandemic. Thank you all for your hard work in keeping us safe during this time. Today's webinar, Immunization in Special Populations, Are You Really Up to Date?, is brought to you by the Canadian Public Health Association through the CANVax project and its partners, Immunize Canada, the IWK Health Centre, and the Institut National de Santé Publique de Québec. I'm Antonella Pucci, CANVax Project Officer with CPHA, and I'll be the moderator for this webinar. Assisting me on this webinar is my colleague Ruchan Zhu, who is also a Project Officer for CANVax. As for a bit of housekeeping, it's important to note that all attendees are muted. However, the toolbox located at the bottom of your screen offers you a few interactive features. For this webinar, the Q&A feature will be used to ask questions. If you have any questions, please type them in the Q&A box. You can do so at any point during this webinar. Only you, myself, and the presenter can see your questions in the My Questions section, and you, as the attendee, have the option to submit them anonymously. When asking a question to the presenter, the question is first read out loud, answered live by the presenter, and then posted in the All Questions section. Feel free to submit your questions at any point during this presentation by using the Q&A feature. All questions will be answered in sequence at the end of the presentation. If you have any questions regarding technical difficulties, please ask them in the Q&A box, and we'll reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live. However, we strongly encourage attendee participation and look forward to hearing your thoughts and questions. As for some quick notes, our webinar is being recorded and will be available on canvax.ca and on CPHA's YouTube channel a few days after the end of this presentation. Second, we would love to hear your feedback. So at the end of this webinar, you'll be invited to take a 5-minute survey to assess your satisfaction and identify any areas for improvement in the delivery of this webinar series. Further, if you haven't already registered with CANVax or subscribed to our newsletter, visit canvax.ca to do so. And finally, for those who may not be aware, we currently added a new COVID-19 resource page on how to maintain immunizations during this time. So if you get a chance, please have a look. But with that being said, I'd like to introduce our speaker for today's webinar, Dr. Pham-Huy. Dr. Pham-Huy is a pediatric infectious disease specialist with expertise in clinical immunology, as well as immunization practices. She's an assistant professor at the University of Ottawa and a member of the Division of Infectious Diseases, Immunology and Allergy at CHEO since 2009. She is the current chair for Immunize Canada and the liaison member on the National Advisory Committee on Immunization. Her research interests include clinical immunology and vaccinology. So with that, I'd like to turn it over to Dr. Pham-Huy. So Dr. Pham-Huy, whenever you get a chance, you can start sharing your slides.
All right, thank you so much for the invitation and the introduction. So I hope everybody can see my slides.
Yes.
Can't answer. Oh, perfect. All right. So I'll dive right in because I actually have a big, I have a lot of stuff on the menu for you guys today with a topic that's dear to my heart. So vaccination in special populations, are you really up to date? This is my disclosure statement. I have no affiliation, financial or otherwise, with the pharmaceutical, medical device, or communications organization. So quick introduction. As people know, vaccine-preventable infections continue to cause diseases across the world. It is not a thing of the past. And there are increasing numbers of different types of populations that are at increased risk of complications from these vaccine-preventable diseases. There are many vaccination strategies and programs that are in place for these groups, but even despite all these programs, many immunocompromised patients, many special populations remain under-vaccinated. And we'll go through a little bit of why that might be. So hopefully on this call, there are a broad audience. I'm going to assume that some are clinicians, some are healthcare providers, maybe pharmacists, public health workers, trainees, people on the front line that actually review immunizations and provide immunization. And for anyone who's worked in this field, hopefully, well, probably you've realized that the work is not simple and our patient population is increasingly complex. And it can be due to a variety of reasons. It could be due to an acute condition. So you might have a patient that comes in and all of a sudden had a acute meningitis, had a traumatic accident and has had a splenectomy. It could be from an increasing aging population or a broader population with underlying chronic medical conditions, as well as patients that are on a variety of different medication or conditions that are immunosuppressive. So I've listed, I think in the intro, a series of questions that I posed to myself, but I'm sure people have thought as well. So which vaccines are recommended specifically for my patient? Who should be vaccinating these patients? When should I be vaccinating these patients? How should I vaccinate the patients? And how can I actually find resources or guidance to help me optimize immunization and understand what's going on? So I get a disclaimer as well. Despite reading a lot on vaccines and reviewing this topic regularly, I always learn something new. And there's lots of things to learn because things are changing and evolving and improving over time. So this is my hope for you today, is that after this session, attendees will be able to describe general principles of immunization in immunocompromised or high-risk patients, to distinguish between low-level and high-level immunosuppression, and to understand how to optimize vaccination in special populations and or immunocompromised patients. I split the talk in half. So the first probably 20-something slides will go over general principles that can apply to a variety of different types of patients. And then I made up cases that could be real or could be fictitious, to illustrate some of these principles. And then what I'm hoping will be to invite a lot of questions at the end, and we might be able to work through some of your real life scenarios. I also have some bonus objectives. So if you have a little piece of paper next to you, you can just write down. You don't have to do it right away. But I would like that at the end of this session, all attendees will have subscribed to the Canadian Immunization Guide updates. I'll give you more details on that. And to download the Can Immunize app. Again, I have no incentive or anything on these. I just think they're good resources. And in my real life practice, I find it useful when providers or patients are aware of these resources. So first statement I'd like to say is that each healthcare encounter is an opportunity to review the immunization status. I view immunization a little bit like a vital sign. And so every time you see a patient, you might weigh the patient, take a blood pressure, and then it's an opportunity to review the immunization record. And one person, and I'll reiterate this along the talk, is the immunization status is not something that is stands still in time. It is a dynamic process because the status or the updated status of a patient will evolve over time according to age, according to health status, according to lifestyle, according to a variety of different scenarios where things might change. So it's always good to review at each health encounter. It also emphasizes how important that is for the patients and for the providers. So one of the first goals, obviously in the realm of immunization, is that we want to ensure that patients are up to date with their immunization status in order to optimize health and avoid vaccine preventable disease. So this is a kind of a trick question that I often ask our trainees. As I ask them, okay, did you ask about the immunization? And they say, oh, yep, they're up to date. But what does being up to date with immunization really mean? So I think you know, in terms of basic, the first definition might be that that person at whatever age they are has received the recommended immunizations according to provincial or territorial schedule. But that's not as simple because, again, as we've stated, health distribution in Canada is provincial and territorial. So if you have a patient that has moved from one province to the other, you should be aware of what the recommended schedule was for that patient at that time. But what I'm really interested in is, so I usually follow up my question to the residents or the trainees, are you really up to date? And what does that really mean? It actually means that, so first, you're up to date according to what is routinely recommended, but you've also considered the other spheres of that patient and to assess the other potential risk factor that that patient may have, which may make them eligible to receive additional vaccines for their protection. So what are those risk factors? There are many. I've just listed a few here where the person may have a underlying medical condition or a health status, whether it's, you know, pregnancy or age, that might make them at higher risk of a vaccine preventable illness or a severity of a vaccine preventable disease to receive additional vaccines. There are also a long list of work or lifestyle factors that also may make that person at higher risk of encountering a vaccine preventable disease or transmitting a vaccine preventable infection. So we know, and it's been reported in many studies, that immunocompromised patients are at risk for vaccine preventable infections. But also we've documented that although they are at risk for more severe disease in some, that this population remains under-vaccinated. Another aspect to realize is just kind of the relationship between chronic medical disease and vaccine preventable disease. So it actually goes both ways. Having a vaccine preventable disease may actually trigger a flare of underlying disease. So it's not necessarily that the infection will be worse, but it might make the underlying disease worse. For example, if you had a person with chronic lung disease and then they have or let's say asthma, having influenza or any viral infection might trigger an asthma exacerbation. And in some cases, having the underlying medical condition, for example, a patient on immune suppression, might lead to more severe vaccine preventable disease. So we said the first goal was to ensure that the patients are optimally protected. So we want to, again, optimize protection, but we also want to minimize potential harm. And this is especially important in the immunocompromised population. So these are, again, we're still in the general principles, and you'll probably hear me repeat myself many times. Sometimes repetition is good for consolidation. So when we're talking about vaccines and immunocompromised, two broad categories of types of vaccines. So the first big categories are the inactivated vaccines. So these are, subunit component vaccines. They don't contain an intact pathogen, but the immune system does recognize it and then is able to mount an immune response. So in general, inactivated vaccines are safe for patients even with a immunocompromised state. However, the question is, depending on their degree of immune suppression, is that vaccine that you're providing going to be immunogenic? Meaning, is it going to actually elicit an immune response, an adequate immune response in your patient? The second broad category of vaccine are the live attenuated vaccines, and we have both live viral attenuated vaccines as well as a few live bacterial attenuated vaccines. And this is where safety or risk becomes a little bit more important, because these are intact but attenuated pathogen that can replicate or potentially cause disease, especially in a patient that has a compromised immune state. And again, because of the immunocompromised state, there's a question mark whether it's going to be immunogenic in your patient. Another question, again, in our initial series of questions, is whose responsibility is it to actually provide immunization? It's on whose to-do list? Is it the primary care provider? And is this the family physician, the pediatrician, the nurse practitioner, the nurse, the pharmacist, or is it the responsibility of the medical specialist or the subspecialist? So in some patients with chronic medical disease, they may actually see their specialist much more frequently or regularly than their primary care provider. The specialist is probably the person that is more aware of their underlying medical chronic condition, the drugs that's being treated, the plan of treatment, the side effects of the medication. And so one might think, well, if they're seeing the specialist a lot, maybe it's the specialist that should be providing the vaccines. However, in many instances, the infrastructure of actually providing vaccines or reside, or better organized in the primary care setting. I should probably put another bubble here, which is public health. In some provinces, the role of vaccinations in general is actually under the realm of public health. So the answer to this question, in my opinion, is that it's actually a shared responsibility. And because if we view the immunization review as being part of each medical encounter, it should be actually reviewed and seen by both. And so that's this might actually change depending on where you work. Some areas it might be more appropriate to be provided in a certain setting, but in general, I think it is the responsibility of anyone who comes into contact with the patient or the client. We should also probably empower the patient client to know to ask the questions and to know what they may need to prevent vaccine preventable disease. So now that hopefully you're convinced that you do need to review the immunization status, that there are diseases that are preventable, how do you actually protect your patient? So again, at least have the routine vaccines that are recommended. There is actually a science and studies of why these vaccines are provided at certain times in a person's life. But even for the routine vaccines, some vaccines might require extra doses in the inactivated, or they might require a higher dose. There are some vaccines that have a live attenuated or a non-live formulation. So if the patient is immunocompromised or on immunosuppressive therapy, it might be safer to provide the non-live version if there is an alternative. Some patients, like we mentioned, might require additional vaccines if they're deemed high risk. And again, those vaccines are in terms of direct protection, but think about indirect protection and to actually review the household. Who's living with this person? Who's coming into intimate or close contact with your patient? And you might want to consider to vaccinate more broadly the household or close contacts. Another important question is, again, when? When should the patient be vaccinated? So two things: they should be in general and ideally vaccinated prior to planned immune suppression, although as you know, not everything in life is planned, and as early in the course of disease as possible. So this is really the concept that there is probably a window of opportunity in vaccinating a patient. There might be multiple windows of opportunity over the course of the patient's life. So even if that window closes, look out for the next one. So again, review your vaccines early. Vaccination status should be assessed and documented at the earliest time point after diagnosis. So if you're a family physician and you're diagnosing your patient with COPD or diabetes or inflammatory bowel disease. This is the time, this should be part of your workup as well. Recommended vaccination should be administered as soon as possible. Because like we said, this window of opportunity or the timing is important. So I'm just going to talk about inactivated vaccines and then live vaccines. So when you're giving inactivated vaccines, in general, when you're exposed to an antigen, it takes about 14 days, 2 weeks to mount at least the initial humoral or antibody response. And so in general, you want to give a vaccine, an inactivated vaccine, at least 2 weeks prior to the planned immune suppression to give the body enough time to actually mount that antibody response. You want to give the vaccine when the patient is on the lowest anticipated dose of immune suppressive agent. For example, if you are now, your patient is on high dose steroids, but you're weaning the steroids and you know that in about 1 month, the patient will be completely off steroids. You may choose to delay that vaccine, depending again on the urgency of providing it at a later date. And if feasible, you may wish to hold or reduce immune suppression temporarily. But in general, again, if the patient needs an immune suppression, the message should be like the active clinical care is the priority, and not to hold the required treatment because of completing the immunization schedule. I would appreciate that passion, but still it would be important to treat the urgent clinical disease first. In terms of live vaccines, the recommendations are a little bit different. We want a little bit more time, both to give time to mount that humoral response, but also because these are live attenuated vaccine, we follow a little bit the replication of the virus. So in general, some of the viral attenuated vaccines that we give, the virus there's a short incubation period and there might be some replication over 3 weeks. So in general, if you're going to start immune suppression, you want to be able to have given the live vaccine more than a month or about more than 4 weeks prior to starting it. If you're already on high dose steroids or something highly immune suppressive, you want to wait at least 4 weeks from stopping high level or high dose immune suppression, in this case high dose steroids, which is considered high dose if it's more than 2 milligrams per kilo per day or more than 14 days, for more than 14 days. If your patient is on chemotherapy, generally we'd like to wait at least 3 months before starting vaccines. Longer for certain ones. So this is just minimum, but generally we actually want to wait even longer. Same thing for anti-B cell therapy. So this is like the rituximab. For allogeneic hematopoietic stem cell transplant, live vaccines are not even considered until 2 years and over in general. There are also accelerated schedules. So if you are again foreseeing some high-level immune suppression in patient in a certain amount of time, and you want to be able to provide inactivated or live vaccine prior to that, some vaccines require booster dose or multiple dose, so you may be able to give it on an accelerated schedule. So this I think I'll go into more details of where you find this resource, but this is from the Canadian Immunization Guide. I get asked many questions related to vaccines on a regular basis, and often I don't know the answer, and I go to the Canadian Immunization Guide. Again, because we're talking about timing, hopefully most people know that there is actually timing between giving blood products and live vaccines. So not inactivated. This is only for live vaccines. So if you're about to give the MMR, the MMRV, or univalent varicella vaccine, if your patient has received blood products, especially immune globulins, you want to be able to check the dose and the time. There's a specific time you have to wait because there might be some residual antibody that would inactivate your live vaccines and make it less immunogenic. Again, that was from the Canadian Immunization Guide. So this whole talk is mainly about immune-compromised patients. So the question of, can I vaccinate an immunosuppressed patient? The answer is definitely yes, but you do have to consider a few things before you go in and create your menu of vaccines for that patient. So the message is that each individual with an underlying acute or chronic condition is different, and it really presents a unique consideration regarding immunization. Guidance of patients with more than one chronic condition is an emerging area, and I think we'll have more guidance in the years to come. So there's not one size fits all. It does require a bit of a review of that specific patient's past history, current active history, and even planned therapies, etc. Just looking at the time. So relative degree of immune suppression, it depends on a few things. So the underlying condition, the progression of disease, immunosuppressive medication, and chronic comorbidities. So these are things that you, when you're reviewing your patient, are going to go through a series of assessment of each of these items. And because I say that this should be reviewed at each medical encounter, because it can obviously change over time. Regarding live vaccine, it's always a balance. There's always a risk between acquiring wild type infection versus the risk of an adverse event with the vaccine strain. And I would strongly encourage people to review what is the actual evidence of the true risk of that vaccine versus the theoretical or anxiety provoking risk, because it feels sometimes anxiety provoking to give a varicella vaccine, for example, to a patient that has some degree of immune suppression. But it's also quite devastating when that patient does encounter wild type varicella and its potential complications. I won't go through this in detail, but essentially there's really a long list of potential immunosuppressive or immunomodulatory therapy. There are a few drugs and dosage, and I'll give you a few just as a guidance that are considered high-level immune suppression or low-level immune suppression, but you really have to take the patient, the drugs, and everything into context. So here are a few guidance in terms of what is generally considered high-level immune suppression. So if you have a combined primary immune deficiency, something congenital. So for example, you have severe combined immune deficiency, definitely these patients would be considered highly immunocompromised. Are you on a patient having active chemotherapy for a malignancy within 2 months of a solid organ transplant? HIV infection, but with the caveats of actually parameters of immune lymphocyte subsets, so CD4 T cells of less than 200 in adults or less than 15% for infants and children. Which means, again, if you have a very high white count, you're viral suppressed, you're asymptomatic, you would not be considered high-level immune suppression just because you have HIV. So it really has this additional criteria. If you're on daily corticosteroids at high dose, and this is, it's considered high dose, greater than 20 milligrams a day, in pediatric patients, so it would be greater than 2 per kilo, or prednisone or its equivalent, given for at least 14 days consecutive, would be considered high-level immune suppression. And at this point, biologics, immunomodulators, monoclonal antibodies are considered high-level immune suppression. But again, this is, I think, there's increasing studies to show that, again, we can't put them all in the same basket, and they have differing immune actions. In terms of low-level immune suppression, like we mentioned, asymptomatic HIV, if you have any kind of lower dose than what's mentioned for the corticosteroids, methotrexate, azathioprine, and 6-MP are drugs that might be used in the treatment of a variety of autoimmune or inflammatory conditions. This was actually studied these dosing were studied well in rheumatological patients, especially with the live attenuated zoster vaccine, so Zostavax, which have shown that they were well tolerated if you are on these levels of drug immune suppressive therapy. So in general, we talked about risk-benefit, immunocompromised in live vaccines. In general, avoid has been the more of the black and white, but we are learning that there are some exceptions. And then I would say, so just to remember that it's in general avoid, but do consider it in certain circumstances. Again, live vaccines have been given for decades in asymptomatic HIV-infected children with mild to moderate immune deficiency. Like we mentioned, the live zoster vaccine has been given very safely in what we consider low-level immune suppression. But also always think of what is actually the risk for that specific patient of wild-type disease versus the risk of attenuated viral vaccine. So if you're on steroids, maybe a higher dose than would be considered low level, but maybe not quite as high level, but that patient is somehow traveling to a measles endemic area. Again, you'd have to generally avoid traveling if you're that immunocompromised, but this is a discussion that would be needed. And in some cases, the risks of the wild type disease definitely outweigh the risks of the attenuated viral vaccine. In immunocompromised patients, if you remember way back, at least 20 minutes ago, we had a slide about vaccines being inactivated being safe, but are they immunogenic? And that went for the same for the live vaccines. And so sometimes in immunocompromised patients, you're not sure if your vaccine was immunogenic. So we do, in select groups, do check the immune response. But we have to understand what are the correlates of protection. And there's only a few vaccines where we actually have been, that has been studied specifically for this. So this is a small list of what we know are correlates of protection. All right, so hopefully everybody's still there, and I'm gonna change gears and go to my a few cases that I hope will generate questions as well that hopefully I can answer. So like I said, I have about 4 short cases just to illustrate a few special population. So oh no, actually before I do that, I'm gonna showcase the Canadian Immunization Guide that if you were around back in, I think this was, well, actually, I was going to say, it's 2006, it's right there. You would have received an actual hard copy of this, but as you know, we have moved on, and the Canadian Immunization Guide is in an evergreen copy on online. It has 54 chapters organized into 5 parts. So we have a lot of the information from this talk. It's also from part 3, the vaccination in special population. And this is the button where it says subscribe for updates. So you don't have to do it right now, but put it on your to-do list. And then you register, because sometimes we do have new information, new science, new epidemiology, and we update these chapters on a regular basis. And so you may want to you may not be reading this on a daily basis, but you want to know when something new is coming out. So then you just put in your email address here and subscribe to updates. Otherwise, you can access the guide online at this link. On top of that, so again, from a federal or national perspective, but if you want to reach out to your own areas in your province or territory, there is great resources. I actually, just to putting this list together, checked out the different immunization manuals and was very impressed. It's really great resources, and sometimes it's nice to have your more local or provincial territorial perspective as well. Okay, so now we'll start with our first patient, 28-year-old male with sickle cell disease. He's new to your practice. Let's pretend you're a nurse practitioner or a family doctor. Comes in and you do the weight, the blood pressure, and you ask for the immunization record, and they say that he says he doesn't have an immunization record or he lost it. And then he does tell you that, yeah, he got all his routine shots as a kid. He does not recall any recent vaccines. Oh yeah, and he's getting an elective splenectomy in about 3 months. And you have like a gazillion other patients to see. But anyhow, so his risk factor is obviously functional asplenia, about to have a full splenectomy, and sickle cell disease. So in hemoglobinopathy or functional or asplenia, the high-risk disease is from the encapsulated organisms. This is a question we like to ask our med students or residents. So pneumococcus, Haemophilus, meningococcus, salmonella. are the big players here, and luckily we have great vaccines for them. And so I've just listed them. I apologize that they're in short form, and I realize as well not everybody uses the same short form. So the PCV13 is supposed to be the conjugate pneumococcal 13-valent conjugate pneumococcal vaccine. This is a 23-valent polysaccharide pneumococcal vaccine. There are increasing numbers of licensed meningococcal vaccines. This is for the quadrivalent conjugate meningococcal vaccines, for which there are a few different formulations, as well as 2 meningococcal B vaccines that are licensed in Canada. Haemophilus influenza B influenza vaccine, and if this patient were to travel, would require or should receive the salmonella vaccine as well. In general, these patients, so they would receive their first series. We would boost with pneumococcal 23-valent once 5 years post the first dose, and we would boost with meningococcal vaccines generally every 5 years. If they were under 5 or 6, I think we would have given it the first boost 3 years post. And again, you'd have to check with your public health area for which formulation is publicly funded for these high-risk groups. In terms of splenectomy, again, logical, I told you it takes about 2 weeks to mount antibodies, so you want to give the vaccines at least 2 weeks prior to splenectomy. But if you, for some reason, missed the boat, then you want to wait a little bit, because post-splenectomy, there could be other post-surgical complication. It's not contraindicated, but it's not necessarily the best time to give the vaccine. Just to be aware that there's increased risk of fulminant bacteremia sepsis with high mortality rate, which is highest in the first 2 years of following the splenectomy, but remains elevated for life. This is really in the context of somebody who had surgical splenectomy, not necessarily functional splenectomy. But just to remember that the risk remains elevated for life. So on your first visit, you give this patient Haemophilus influenza B, because even if they've received this vaccine in childhood, we give at least one in adulthood. You give the MenB vaccine of your choice. You give the quadrivalent meningococcal vaccine of your choice, PCV13, on the first visit. You repeat the meningococcal quadrivalent conjugate vaccine in 4 weeks. MenB depends on the formulation, so this is, I must admit, meningococcal vaccines, they have different schedules, but again, all the answers are in the Canadian Immunization Guide. And then you give your first dose of 23-valent polysaccharide pneumococcal vaccine 8 weeks after the first dose of conjugate pneumococcal vaccine. Again, you realize, I hope you realize that there are some that require second dose, third dose, but in general, these are in the Canadian Immunization Guide in each vaccine section or in the special population. And I also checked, in most provinces and territories actually have a cheat sheet or a synopsis of what should be provided for select high-risk group. And then you ask your patient to download the CANVax app and have their immunization record on their mobile device, because everyone has a mobile device these days on them. And in case you do not know what it is, it's essentially a digital vaccination record for Canadians. And it's a little bit more cumbersome at first to enter it, but after that, it's easy peasy and very useful. So moving along to case number 2, if I may. We have a 55-year-old man or woman with type 2 diabetes, also has chronic kidney disease, also on hemodialysis, and as well is awaiting a kidney transplant. So I've underlined a few risk factors for this person. So chronic kidney disease, people with chronic kidney disease have many reasons why they may be at higher risk of complications from a vaccine preventable disease or having that disease exacerbate their underlying disease. Often people with chronic kidney disease may have other comorbidities as well. With progressive kidney disease, there are immunological changes that occur. They may have a less robust T-cell response. They may have proteinuria and lose antibodies through their urine. There may be altered immunogenicity or response to vaccines, sometimes often require a higher dose or more frequent boosting. These patients may have central line, peritoneal dialysis catheters. They may, with dialysis, they come into healthcare exposure on a regular basis, blood exposure to blood products. They may have overall potential immunosuppression due to therapy or uremic state. So in general, pneumococcal and Hep B, amongst others, are main vaccines to keep in mind. Hepatitis B in general, for somebody with chronic kidney disease or on dialysis, you want to give a double dose. So you want to double whatever dose is for the formulation you give. So there's there's generally 2 different hepatitis B vaccine formulation. You would essentially give the same the same schedule, but double the dose for that patient. The pneumococcal vaccine, as we mentioned, we generally give the at least an adult dose of the conjugate pneumococcal vaccine, followed about 8 weeks after by the 23-valent. So if people mix this up, you always give the conjugate before the polysaccharide. So C comes before P, 8 weeks apart. And for these ones, as we talked about correlates of protection, we actually do recommend to check the anti-Hep B titer 1 to 6 months after completion of that vaccine series. And then we subsequently recommend to do it on a yearly basis because the titers could come down. They may have rapidly waning immunity, and as they have a frequent exposure to blood product through dialysis, etc. It's in bodily fluids. It's recommended to maintain an elevated anti-Hep B titer of over 10. Diabetes, as we mentioned, similar reasons why you might have complications and the associated comorbidities, again, with somebody with advanced diabetes, which can lead to complications with the VPD. Prevention of influenza and pneumococcus is also highly recommended. So third case, 30-year-old pregnant woman, also has inflammatory bowel disease, on infliximab, preconception, and throughout her pregnancy. So immunizations in pregnancy is a whole other chapter. I think we all appreciate that pregnancy itself is a altered host immunological, not immunologica state. 2 main VPDs, influenza and pertussis. To make it simple, essentially give pertussis vaccine and influenza vaccine for every single pregnancy, regardless of history. Obviously, the seasonal influenza would have to be during the season, but essentially pertussis vaccine for each pregnancy. Often the barriers to providing adequate immunization in pregnancy is sometimes failure for the healthcare provider to actually recommend the vaccine. It's just maybe not part of the routine, although I would say that increasingly it has become a vital sign in pregnancy. But sometimes it's also the logistics of providing the vaccine. Not every OB office has a vaccine fridge and is able to do so. And then there's misconceptions of safety and benefits potentially for these vaccines in pregnancy. A quick word on chronic inflammatory disease and patients on immunosuppressive therapy. So in general, pneumococcal, influenza, both of these generally for most chronic condition, it would be recommended to provide. There are some, like I said, immunosuppressive drugs that you could give varicella vaccine if benefits outweigh the risk, but not in this context of pregnancy. So this was just to illustrate somebody who is on low dose immunosuppression. But in general, again, avoid live vaccine if you are highly immunosuppressed. I'm gonna just skip this here. And then one slide on an emerging topic of immunization of infants that are exposed to maternal immune suppression. So as you may know, certain immunosuppressive medication that are used in pregnancy to treat the maternal disease can cross the placenta and therefore impact the infant. In general, for the infant, all inactivated vaccines are okay, but caution with live vaccines depending on the drug exposure. And because this is again an area with increasing studies and experience, we do recommend to refer to a clinic that is familiar with these types of patients. In Canada, we have the special immunization clinic. I think I'm going to actually skip over the last case, which is an adolescent with leukemia, if I may. Just for sake of time, I really want to make sure I have time for your questions. So again, just a few general principles before we conclude. Think of the vaccinate your patient, but think about it broadly. So we talk about vaccinating the household. When I have an immunocompromised patient, I do go through the whole, like who's living with this patient, who's coming into regular close contact with your patient, and make sure that they are up to date for the routine, but also make sure they had their, their adult booster of pertussis. If they're over 65, they get the pneumococcal vaccine, that they're up to date, 2 doses of MMR, varicella, and they get the seasonal influenza vaccine for the whole household. In general, all vaccines are okay. There are some vaccines that might shed, but it's unlikely to cause disease in the immunocompromised patient. And so in terms of risks of transmission, excessively low. For the rotavirus vaccine, for example, it is shed in the baby's stool, generally higher during the first week post-dose. So as long as you wash your hands carefully when handling the diapers, should be okay. Same thing with if a person in the household develops a mild varicella rash after the vaccine, to cover the blisters. The only one we say to avoid is the oral polio vaccine, but fortunately it is not given in Canada. Everyone should get the seasonal influenza vaccine in the household. Living with the immunocompromised patient, in general with the inactivated influenza vaccine, again, benefits outweigh the risks and potential decrease in immunogenicity for the patient. So even if it may not mount the best response in your patient, they may have some benefit, and again, the risk of the vaccine in that patient is probably much lower than the potential benefits. So just to recap, I've talked a lot. General principles: vaccinate at optimal time, vaccinate broadly, give boosters accordingly, assess the risk benefit of live vaccines versus live disease, monitor serologic response if indicated. And one last slide, like it was mentioned at the beginning, we are unfortunately in a pandemic, and many public health measures have been taken to limit the transmission of COVID-19. And in many cases, deferral of non-essential medical visits or in-person medical visits have been recommended. But immunizations, particularly in infants and toddlers for the first primary series, is an essential medical visit. So I'd just like to conclude with that, and checking the time. I hope it's okay. I guess this is the part where people ask questions.
Yes, it is. So thank you so much, Dr. Pham-Huy, for your presentation. At this point, if anybody has questions, please submit them using the Q&A feature. It looks like we have about 6 questions we're going to get through, and looks like we have about 10-ish minutes for questions. So we'll just start getting through them. And just to mention, there was one question that was already answered. Will the slides be available? Yes, the slides will be available when the webinar recording is available. All right, to get started, we have a question from attendee that says, it seems prednisone is the only steroid ever mentioned. Does the greater than 2 micrograms or kilograms per day apply to all steroids? Is there a list of steroids that we can refer to? And there was also a follow-up from that question as well. Is there a list of equivalent doses for immunosuppressive medications, comparing, say, prednisone with other steroids? I don't know if you want to go question by question with that. Sorry.
Yeah, so just, so it's hard to keep like, like specific. And as I say, like, I try to give some guidance. So they always say prednisone because it's the most commonly used. And what I generally say is, so greater than 2 per kilo generally would be reserved for something highly inflammatory or autoimmune during a flare, for example. So if it's being used for, so it's generally not a asthma exacerbation dose or and usually asthma exacerbations are given for 5 days, 3 days, short courses, so not 14 days and more. When in doubt, so there are a few tables. It's actually not in this Canadian immunization guide, so now I'm lying to you. There are other resources so they have a corticosteroid equivalent. Often I might refer to, so this is, in the context of an acute flare, in general, you would not use it. That would be considered high-level immunosuppression. If you're on it chronically, so more than 14 days, I would ask, like, if you're the prescribed, so for example, if you're not the one prescribing the corticosteroid, I would ask that question to the person who prescribed, who's treating whatever flare, inflammatory or autoimmune flare that person is having, to see if it's going to be decreased, or what is the purpose, or is this considered high level or like high doses in that area. But I wonder if that person can give me more specific, because it's, in general, they're short courses, even a high dose, but short course is okay. Definitely IV would be considered high dose. If you're getting pulse steroids, it would be considered high dose. But inhaled corticosteroids would not be considered high dose. If you're having, let's say, a dermatitis or a rash, and you're getting steroids for, again, a short, like a couple of days, that would be considered low level. I'm not sure if I'm answered that question.
Like prednisone and cortisone.
So some people are on regular cortisone or physiologic doses of corticosteroids, so those would again not be considered. I don't know by heart the exact dosing equivalent of cortisone compared to prednisone. I rely more on why is that person receiving, like what is the indication of that person's steroid dose. That sometimes gives me a clue of if it would be considered high level or low level.
All right. And just another follow-up, something to compare or state high-level doses of all steroids. That's also what the attendee is clarifying.
Okay. Yeah, so same in that line. That might be, again, something that if people find it useful, we could incorporate that into the Canadian Immunization Guide as well.
All right. Awesome. So I'm just going to get to the next question. So this attendee is asking, if a patient is on a regular medication schedule, Remicade or biosimilar, every 8 weeks, is there an optimal time to receive an annual flu shot? Should it ideally be 2 weeks before the next planned infusion?
Yeah, so that question has come up a lot with our gastroenterologist, and the answer is that not necessarily try to like time it with an infusion or not, or so just give it, because again, if you're controlling the disease, it's actually probably more important to have like control of disease, but to not necessarily have to do it before or after. So there was no consensus. We actually reviewed this on a panel of IBD specialists, and it was just give the flu vaccine.
All right, thank you. So another question from another attendee. Is there residual antibodies and immunoglobulins or blood products from a donor who has only received vaccines for measles, or are there only residual antibodies from donors who have had measles disease? Hope this question makes sense.
Yeah, so right now the immunoglobulin products that we have are mostly from probably a mix, but increasingly vaccine-induced immunity as opposed to natural measles. So yeah, there's a collection of both natural disease and vaccine immunity. Right, for all measles. Same with varicella increasingly, although maybe not, they're still a relatively young cohort. Yeah.
Right, awesome. This is a comment from an attendee. On the list of immunization schedules, I think one of your slides you shared, I did not notice if the Newfoundland and Labrador immunization manual
Oh my
was
God, yeah.
displayed.
Yes, I think you might be right. I may have missed, I apologize. I apologize for that. I will add that before I submit.
And we
Thanks
have
for
another.
pointing that out because they do have one. I did see it.
All right, we have another question, and apologies, this is attendee. My shorthand is awful, so I'm just going to read it. PPSV23 is often a vaccine that physicians indicate they want their clients to receive even after they have received 2 doses appropriately. Do you have any information to refer to that indicates why it is not beneficial to receive at most 2 doses?
Yeah, so right now the recommendation is just to give that first dose followed by a 1 lifetime boost at least 5 years after. There are some studies showing that if you give more, you have a hypo-responsiveness to the vaccine. And so what has been studied right now is just 1 booster. And there are further studies to see if this phenomenon actually, but there is some suggestion that giving too much is actually not a good thing for this specific polysaccharide vaccine.
Awesome. And then the final question I have on my list, attendee is thanking you for your general questions on pneumococcal vaccine. And their question is, when do we decide to give Prevnar in addition to Pneumovax, especially in cases where it is up to patient and provider to decide?
So there are lists of, so each province and territory have a high risk, like a publicly funded high risk program. And so if your patient fits the high risk for invasive pneumococcal disease, they would be eligible to receive or they should be eligible to receive a conjugate, like the 13-valent conjugate pneumococcal vaccine, as well as the polysaccharide pneumococcal vaccine.
Right. Thank you. We have another question that came in. Once again, apologies. Shorthand is not my forte. So what if PT got, provincial and territorial,
Sure, yeah.
got PPV 23 2 doses before 60 years old? Need another one after 60? Do you need another one after 60 years old?
So in general, you should not give the PPV 23 or the 23-valent polysaccharide pneumococcal. That's why I say shorthand, because it's so long to say. But if you generally don't give it under age 2. So let's say you give it exactly at age 2. You could, you generally give it at age 7. So, and that would be, at this point, this is the guidance. You would just, that would be it.
Right. Thank you. So it looks like we have no other questions. That concludes the end of our webinar. And for any folks who do have additional questions, we'll be sending a follow-up email with the webinar recording and the slides, as well as a way to contact Anne through us. So with that, thank you.
Again, apologies to Newfoundland and Labrador. It's not intentional.
So thank you all for joining us on today's webinar. Thank you again, Dr. Anne Pham-Huy, for your wonderful presentation. As a quick reminder, please don't forget to fill out our survey upon closing the webinar window on your device. We look forward to your feedback. Thank you all. Have a wonderful afternoon and stay safe.